Okay, we're going to go ahead and continue here our discussion on long-term controls of blood pressure, the long-term mechanisms. As we started on this yesterday, the mechanisms we use are going to be altering blood volume. So remember, everything we drink ends up in our blood. Fluid levels rise, blood pressure goes up. Fluid levels drop, blood pressures go down. So we can tell when the pressure rises, the baroreceptors in the carotid sinus, the baroreceptors in the aortic arch are going to detect this. The kidneys will detect it by the rate of filtration. Higher pressure causes the filtration rate to become faster. So the kidneys are going to alert us, and so are the baroreceptors. If our blood pressure goes up, the kidneys will swing into action by releasing more water. Now we excrete more water. Uh, we're producing a more dilute urine through the collecting duct. We may be excreting sodium to get the water to leave, but that's the first attempt here to this is our major long-term mechanism here to regulate blood pressure by getting rid of the blood volume. We're getting rid of the water volume. The water volume is going to be, all water at some point ends up in our plasma, whether it's going to be plasma or interstitial fluid or lymphatic fluid or filtrate and back to plasma. It's still going to be in our blood. And the more water we have in our blood, the more fluid in our blood, the greater the pressure, the greater the volume we have, the heart has to beat faster. The faster the heart beats, the more frequent the higher the heart rate, then the higher the pressure is going to be. If we get rid of excess water by getting rid of sodium, because remember, water will follow sodium, then we'll lower the blood volume, and that lowers blood pressure. If our blood pressure is too low, the kidneys will go into action by stimulating renin, angiotensin, aldosterone. The kidneys will retain water by retaining sodium. Aldosterone causes us to retain sodium. If we retain sodium, then we retain water. Remember that water follows salt. So the sodium will draw the water to it, osmotically, the water. You increase the osmotic concentration on one side of a membrane with more sodium, and water will follow it. So what happens if our pressure is low, then the kidneys will detect this. Again, as in the filtrate, they'll detect the lower pressure. They'll produce renin, which will activate angiotensin, which will activate aldosterone. Aldosterone tells us to retain sodium in the distal convoluted tubule of the kidney. We'll talk more about that in the urinary system. And that will tell us to retain water. And so we raise our blood volume, we raise our blood pressure. So we have two methods here then of direct and indirect to control our blood volume and control our blood pressure. The direct mechanism involves the altering the blood volume itself by either retaining water or releasing water, one or the other. And so our response is to pee it out or retain it. We raise the volume, we retain sodium, so we retain water. We excrete sodium and we lose water. That's our direct mechanism. The indirect mechanism, of course, is renin, angiotensin, aldosterone. When our pressure is low, we can stimulate aldosterone to retain sodium. Sodium gets retained and water gets retained, and our pressure can go up. And so that is the indirect long-term control. And of course, this very busy flow chart here, I mentioned this yesterday, shows all the things that can happen. The baroreceptors detect that change in pressure. Pressure is low. That will have a sympathetic nervous system response to the kidneys to trigger renin release. Renin will trigger angiotensin 2 and aldosterone, and we know the sequence there. Uh, Angiotensin 2 also is a vasoconstrictor. So there's another mechanism we use to raise blood pressure. We constrict the blood vessels. And so that by when we constrict the blood vessels, the vessels are narrower, the pressure is greater because the resistance is higher. So we're squeezing the vessels first. Angiotensin 2 is also stimulating aldosterone. So now we have the other mechanism here of retaining sodium to retain water. So we constrict the vessels with angiotensin 2, and we retain water by retaining sodium. Our pressure rises because there's greater resistance. Our pressure rises because we increase the blood volume. So now, how do we know how efficient our system is? You know, how well are we pumping blood throughout our bodies? Well, we can take our blood pressure. It's a very simple mechanism. We do that all the time when we go to our healthcare provider. You go into your healthcare provider's office, they're going to take your blood pressure, they're going to take your pulse, they're going to take your breathing rate and your body temperature. Mostly, if we use a pulse oximeter, then you'll detect oxygen saturation levels too. Now, our blood pressure is monitored with a device known as a sphygmomanometer. That's the proper term for a blood pressure cuff. We monitor it. We monitor blood pressure at the brachial artery. We put this inflatable cuff over the arm around the brachial artery. We pump up pressure inside this cuff until the pressure in the cuff that is supplying to the brachial artery is greater than the systolic pressure in the artery. The pressure in the artery, the blood in the artery, the highest pressure of the blood in the artery will be from the systolic pressure. So we were talking about the vital signs, blood pressure, pulse, respiratory rate, body temperature. These simple evaluations can give our healthcare providers a great deal of information. We monitor blood pressure, we monitor pulse, breathing rate. The pulse is nothing more than the expansion and relaxation of the elastic fibers in the walls of the artery. So every time a surge of blood comes through the artery wall expands, it stretches out, and then as soon as the surge goes through, it snaps back, and we have a pulse. The probably the easiest location to take your pulse is at the radial artery. Now, the radial artery is directly behind your thumb. You can place your two fingers in let's see if I can take this screen off of sharing and show you. Let's see, put the camera on, and now I hold up my hand here, and there's your right thumb, and the radial artery is running directly along the radius. You have the radius in here and the ulna in here, and you have a radial artery that's going out to the hand, and an ulnar artery going out to the hand, and a radial vein coming back, and an ulnar vein. It's nice that arteries and veins usually run side by side. If you place two fingers in this area right here, directly behind the thumb, you'll be able to detect the pulse. You can feel your pulse right there and start making a count. You can feel the expansion and relaxation every time from here. Simply by knowing where your thumb is, you can tell where to take the radial pulse. I mean, again, if you know where your thumb is, you know where your radius is, you know where your ulna is located, you know where the radial artery and the radial vein and the ulnar artery and ulnar vein right there. So let's get back to where we were. Now, so depending on our activity levels, our pulse will go up or go down. If you're standing up and walking around, the radial pulse, or any of the other locations in your body where you could take the pulse, the carotid sinus underneath the earlobes, about an inch below the earlobes, in the neck, uh, activity levels will cause a change in your pulse rate. The more active you are, the higher the pulse rate is going to be because your heart's going to be contracting at a faster rate. If you're reclining, you're going to have a lower pulse rate. If you're standing upright, you're going to have a higher pulse rate. If you're walking, your pulse rate will change. If you're running, your pulse rate is going to change. So our blood pressure is going to vary over time. It will, over a 24-hour cycle, it has its own circadian rhythm. Uh, our blood pressure is usually the highest in the morning and lowest in the evening. But there are other factors, which there are, I should say, there are other factors which affect our blood pressure and our heart rate. Our age may affect our blood pressure. The older we get, we may see changes in the efficiency of our heart or our circulatory system. Our sex may have an impact on our heart rate, of our blood pressure. Our weight, a person who gains weight is likely going to have a higher blood pressure because there are more blood vessels to fill with blood, meaning the heart has to work harder. There is a race component to blood pressure. Apparently, some different racial characteristics are going to affect blood pressure in some individuals. Our mood. How do we feel? Do we feel good? Do we feel bad? Are we angry? Are we happy? That will affect our blood pressure. How we stand affects our blood pressure. Our socioeconomic status. Are we worried about money? Are we worried about food? Are we worried about survival or not? That will affect our blood pressure and physical activity. Any of these and none of these may affect our blood pressure. Now, blood flow through our organs is regulated so that we want to be consistent. We want to be constant. So we are going to send blood through our organs at a consistent rate, depending on what that organ needs. In other words, if you have just eaten a large meal and you're about an hour after eating that meal, and we are processing food through the esophagus into the stomach, the final digestion takes place in the first 12 inches of the small intestine, the duodenum, and then we go into 20 feet of absorption. Well, that's going to require an increase in blood flow to the small intestine to pick up these nutrients that are being secreted through the walls of the small intestine or absorbed through the walls of the small intestine. So that's going to have a higher demand for blood at that point in time. However, later on, after you've gotten through that absorptive phase, you're not going to have as much blood going to the small intestine as before. Depending on the size of, first of all, depending on the demand, and then controlled by the size of the arteriole. Is it dilated or is it constricted? That's going to determine the blood flow through the various organs. It's not going to be a constant, not every organ is going to have a constant flow all the time. Skeletal muscles may have a higher demand when you're exercising than they do when you're asleep. The small intestine will have a higher demand when you're absorbing nutrients and a lesser demand when you're at rest. So it just depends. From a systemic perspective, our mean arterial pressure, remember mean arterial pressure, is the diastolic minus 1/3 of the pulse of the one-third of the pulse pressure. The mean arterial pressure in our bodies will stay constant. As long as it's above 60 millimeters, we're fine. That's an overall value. But the various organs will have changes based on what their demands are, what their needs are, what do they want, what do they need. And so we're going to see these changes here uh, over time as we eat, as we exercise, as we drink, as we sleep. The various organs will have greater or lesser demands, but the overall mean arterial pressure will not change. Okay. Now, the what is the trigger to maintain this auto regulation? Well, if our glucose levels go down and our oxygen levels decline, we're using more glucose, we have greater oxygen demands, we will kick into we'll maintain those levels through auto regulation. We don't have to stop and think, oh, my oxygen levels in my in my leg muscles are getting low. I better increase the heart rate to send more blood to the the muscles of the leg. No, it's an auto regulatory response. If we're using more glucose and we are using more oxygen, then we will, if we're using more glucose and more oxygen, we will then, our autoregulatory response will be to vasodilate, to increase blood flow. Hemoglobin will, nitric oxide will get released. Hemoglobin will carry the nitric oxide as well as the oxygen to the capillaries. The vessels, the arterioles leading to the capillaries will increase and upload, so we can upload more blood. So, uh, it's usually nitric oxide here is the major player. The demand is going to be more glucose or more oxygen, but the response is going to be if we need more oxygen and we need more glucose, we're going to increase the flow by dilating the vessels, and that's where nitric oxide gets released to have a change in the diameter of the vessel. Now, it may be a localized change because we certainly don't need to have all of our vessels dilated just because the skeletal muscle needs more blood. So other things that can affect our the movement of blood through our system to meet demands. We have the ions potassium, potassium ions, hydrogen ions, histamines, adenosine, prostaglandins, lactic acid. All of these are going to cause changes in the blood flow on maybe a systemic or maybe just a localized response. Now those were let me go back to those. Those are what we call the metabolic controls. We are low in nutrient, we're low in oxygen, and so we have to find a way to boost that. So metabolically, then we release nitric oxide. Now we also have what are known as the myogenic controls. These are dealing with the muscle. Myogenic means muscle. The metabolic is going to be chemical control. Metabolic controls nitric oxide or potassium or histamine. Histamine is a very powerful vasodilator. Your nose runs when you're exposed to pollen. It irritates the histamine receptors in your nose, and we cause vasodilation of the arterioles in your nasal cavity, and your nose runs to wash away the irritant. So it's response to histamine. That is a metabolic response. Here we're dealing with the response of the muscles. If we don't have enough blood going to an organ, or our pressure is very, very high, what will happen is these myogenic controls built into our system that are autoregulatory, we don't have to think about them, will control the smooth muscle that surrounds our blood vessels. So if our blood pressure is too low, if we need more flow to a specific organ, then we can trigger the release of norepinephrine into the smooth muscle, and the smooth muscle around the vessels will constrict. So we will have vasoconstriction that raises the pressure. The pressure is higher now. So we're going to increase the flow. Well, we're not going to. We're going to raise the pressure to respond to the demand. If we want more blood flow, so if our pressure is low, we can vasoconstrict. If our pressure let me rephrase. I don't want to confuse anybody. If our pressure is too high, we can regulate by using our sympathetic nervous system. If our pressure, well, if we need to respond to a change in high pressure, we can reduce the flow through a structure through vasoconstriction. The glomerulus is a really good example of this. The glomerulus has an afferent arteriole controlling blood going into the capillary bed of the glomerulus. So if the pressure gets too high inside the glomerulus, if the overall blood pressure is too high, we can constrict the afferent arteriole to reduce the flow, lowering the pressure in the glomerulus. So the muscles that surround the smooth muscle that surrounds the arterioles is very responsive to the release of norepinephrine. And so if we need to reduce the pressure, we can constrict the vessels. Sort of sounds counterintuitive here because when you constrict the vessels, that's another way of raising pressure. But here in the glomerulus, for example, if we want to reduce the flow going into the glomerulus, we can vasoconstrict. So by simply sending out more norepinephrine. Now, if we want to increase the flow to a structure, then we would stop sending out so much norepinephrine to the arterioles. The smooth muscle relaxes, the flow increases. Perhaps the overall, again, back to the glomerulus, if blood pressure is too low and we're not filtering blood as fast as we should, then our afferent arteriole will get less stimulus from the sympathetic nervous system. We'll have less norepinephrine going into the smooth muscle. The smooth muscle of the afferent arteriole will relax and it will dilate and more blood will come in. And so here, what we're trying to do in the glomerulus again is if our pressure is too low, we want to bring it up. If our pressure is too high, we want to bring it down so that we can maintain a constant pressure through the kidneys. And this would apply at any organ where we have too much pressure, too much blood going through there under greater pressure. We can restrict that by simply constricting the arteriole supplying that capillary bed. If our pressure is too low, we can dilate that arteriole and increase the flow. Yeah. Long term, that was a short term fix. A short term fix, you're for whatever reason you're not getting enough blood going through your kidneys on a short term basis, or maybe you need more blood to go through into the skeletal muscle. For whatever reason, you're fixing a short term problem of either high pressure or low pressure. Long term control is different. Autoregulation can't help. Short-term autoregulation can't help a problem. You may have a problem which lasts for weeks or months that develops. It may take a long time to build up enough blood vessels. This autoregulation, this long-term autoregulation is going to trigger what we call angiogenesis, the creation of more blood vessels. Our body will make more blood vessels as necessary. And so when we need more blood vessels, we can make more blood vessels. And so we increase the number of vessels to satisfy greater tissue demands. When a person grows, from infancy to adulthood, we generate more blood vessels. Our body gets bigger. The large vessels in our body enlarge, but as we add more muscle tissue, as our muscles enlarge, or our bones grow, we have to have more blood vessels to supply them. So we generate blood vessels. If we gain weight, the more weight we gain means more tissue. That tissue has a demand for more blood supply. And so we generate uh, more blood vessels. Angiogenesis increases the blood vessels, and we generate more blood to fill those vessels, so we have more fluid and we have more formed elements. And generally, what happens is the heart has to work harder to satisfy the demands of the higher level of blood volume, which usually leads to higher blood pressure. So, angiogenesis will occur when basically what it means is we're going to generate more vessels. Angiogenesis can occur when vessels get bigger. And so they will enlarge. If a vessel enlarges, we may generate additional vessels to support it. If a vessel becomes partly blocked, like in the heart, we will have this workaround. Angiogenesis will create smaller vessels, smaller arterioles to go around the partial blockage in here. And that becomes, it's a workaround. It's not a good thing because a person with blockage in a coronary artery isn't getting blood supply to the muscle tissue below the blockage like it should. So it has this workaround, and that's fine for basic normal activity. But any kind of stress or sudden increase in physical activity will overwhelm those new arterioles that have been created in here. So we, you know, often a person that has a blockage and doesn't know it will often discover that they have a blockage by having a massive myocardial infarction simply because the amount of blood that they're trying to send through the partly blocked artery and through the small arterioles isn't enough to meet the demands, and the heart says, I can't deal with this, essentially. Also, we will generate more vessels when we're dealing with higher altitudes. If we were to live at 10,000 feet let's say, in the Rocky Mountains, then we would easily generate more vessels because at 10,000 feet, we only have half the available oxygen that we would have at 1,000 feet like we have here. And so we increase the number of red cells to compensate for that. We increase the number of blood vessels to deliver the oxygen we do have available to us. And once we acclimate to the higher elevation, we don't notice it. You know, we only notice that change in elevation if we go there. We travel there, and we're not used to the reduced oxygen levels. As they say, the air is thinner. It's because there's less. There are only half as many oxygen molecules as there were before. There's only half as many nitrogen molecules as there were before too. So the percentages of 80% nitrogen and 20% oxygen are maintained. There's just less of them, less molecules of them. And our bodies don't like that. So we adapt. So temperature regulation. We use our blood vessels to help control our temperature. When we exercise, we get warmer because you know that only 40% of the energy released from a molecule of sugar is used to make ATP. The rest of it comes off as heat. That's what gives us a constant body temperature. But the more we exercise, the more glucose we burn. The more glucose we burn, the more excess waste heat's coming off. 60% of the energy in a molecule of glucose comes off as waste heat. We may be exposed to a very warm environment. We may have a fever. So what we will do is we try to get rid of this excess heat. The hypothalamus, which is monitoring our temperature for us. Remember, the hypothalamus is often considered the thermostat of the body. And the hypothalamus, when it detects a rise in temperature, will um, will tell our smooth muscle to dilate, increase the flow, particularly to the skin, so we can radiate heat away from the surface of our skin. Uh, Also, the the excess heat coming up through these capillaries near the skin, because remember, we don't have a blood supply. The blood supply stops at the dermis. It doesn't go into the epidermis, the outer layer of our skin. Well, what we do is we run more blood into the dermis where we have our vessels, and this heat is being transferred to our sweat glands, to the water in our sweat glands. So when we perspire, we are carrying that heat out with us. And then when we perspire, we release perspiration, sweat. We sweat, and that warm water coming out of our sweat glands evaporates, and we are releasing the extra heat that way. So we send our body excess body heat to the surface of the skin, and we lose it through evaporation. We lose this extra heat. That's why we sweat on a hot day, is to get rid of our body heat. On a cold day, we're not going to be sweating. On a cold day, we are going to vasoconstrict most of our vessels leading to the skin. We're going to reduce the flow going into the capillary bed supplying the skin. And so we're going to try to minimize the amount of heat loss. So instead of sending a lot of blood to the skin on a cold day, on a cold morning, you're outside, you're going to send less heat, less blood, and less heat to the surface of the skin. You don't want to lose any heat. You want to maintain as much body heat as you can, and it tends to stay more in towards our core, towards the organs themselves. So we regulate our body temperature as best we can in a hot or cold environment by depending which way the blood's going to go. Are we going to send more to the dermis to radiate heat away from the body, to heat up the sweat so it can evaporate off the surface of our skin and cool it down, or are we going to restrict the flow so the blood stays deeper near our core? So we also send blood to the lungs. Now, the lungs are more than just picking up um, oxygen and getting rid of CO2. We give off a lot of moisture through our lungs too. The arteries the pulmonary arteries are going to they're going to be very, very low pressure. You know, the instead of 120 over 80, which we would have in our, in a normal blood pressure taken at the brachial artery, our blood pressure might be 24 over 8. It is very low. We don't want to send high pressure blood into the lungs. The lungs are simple squamous structures. We don't want to rip them apart. As the analogy of the wet single ply toilet paper, it's not the ideal analogy because that's still too thick compared to what the lungs are, because the lungs are only like 0.05 micrometers in size. We can't comprehend something that small, that thin. But, it's like turning a fire hose onto a sheet of single ply toilet paper. If you were running in at 120 over 80, you'd blast apart the lungs. So we keep the pressure very low. The arteries, the pulmonary arteries, the pulmonary trunk comes up out of the right ventricle and branches into the left and right pulmonary arteries, and they branch into the arterioles. And these are very thin-walled structures, they're very large structures. They're bringing a lot of oxygen to the lungs, so they can be reoxygenated. If our vessels, if we are exposed to low oxygen levels, we will vasoconstrict. If we are under high levels, we will vasodilate. So vasoconstriction, so we don't want to, lose oxygen. Vasodilation, so we can gain more oxygen. This is the vasoconstriction and vasodilation is the opposite of what most structures do with our blood vessels. Normally you would expect if we had low oxygen, we would vasodilate, but we don't. We vasoconstrict. Because we're trying to minimize oxygen loss from the blood in the lungs. if we have high levels of oxygen, we vasodilate to grab more oxygen. So most of our other organs work exactly the opposite. Now our heart has its own blood supply. It has its own flow. The first 5% of the blood leaving the aorta comes off the left ventricle. The aorta is the major blood vessel that delivers the systemic circulation to the whole body. Well, the right and left coronary arteries are the first vessels that come off of the aorta, and they feed the heart. The heart does not get blood supplied through the chambers, through the right and left ventricles. The walls of the chambers are too thick. We have our own coronary circulation. The circulation in the heart depends on the blood pressure in the aorta. The aorta is under like 120 millimeters of mercury pressure, and circulation is affected by the contraction of the ventricles. When the ventricles contract, the blood flow through the heart itself momentarily stops. So now at systole, which is what I just said. Now the proper term here, ventricular systole, ventricular contraction. When the when the cardiac muscle contracts, then all of the coronary blood vessels in the coronary circulatory system, not what's going out of the heart, but what is feeding the muscle cells of the heart itself, those vessels are going to be compressed, and we're going to stop sending blood through the muscles. Well, this is a very, very short time frame. The entire cardiac cycle takes 7/10 of a second. The actual contraction phase takes about 2/10 of a second. Most of the cardiac cycle is in the diastole or rest phase. So, and the heart doesn't mind because the heart uses myoglobin. Myoglobin is a respiratory pigment, just like we see in skeletal muscle. It's what makes skeletal muscle look red. It's what makes the cardiac muscle look red because of the presence of myoglobin. It stores oxygen, doesn't carry it like hemoglobin does, but it stores oxygen. The more oxygen it stores, the redder it's going to get. So we have more stored oxygen available in the cardiac muscle cells held by myoglobin to meet our needs. And so the heart, circulation through the heart momentarily stops for 1/10 of a second at the point of contraction, but the cells are still being supplied with their oxygen needs thanks to the myoglobin. As soon as contraction's over, we move into diastole, the rest phase, and then the movement of the blood through the coronary vessels picks up and continues. And the diastole phase is probably about 5/10 of a second, about a half a second. In the 7/10 of a second that it takes to go through the cardiac cycle, about 2/3 of it you're going to be in the rest phase. Now, typically when we're at rest, blood's going to flow through the heart. It's going to be the control of the muscles. The muscles will contract. The blood flow ceases temporarily through the vessels. Then the vessels relax and blood flow continues. But the cells are happy because they have lots of myoglobin that keeps them fed. That's at rest. So like you're sitting down right now watching this video, then you're likely at rest. However, if you're watching your video while you're working on your treadmill, you're probably not at rest. I don't know why you'd be doing that anyway, but let's just say you were. You would be engaging in strenuous exercise. So, totally different response. During exercise, we're burning glucose. And that's what we do. We burn glucose after about 60 seconds or so, where we've been running anaerobically when we're exercising, and we're starting to burn glucose through cellular respiration. We're giving off carbon dioxide there. We're releasing about 36 ATP, and we're giving off about 60% of the energy that we're releasing is coming off as body heat, but we're giving off carbon dioxide. Carbon dioxide is detectable by a change in blood pH. Carbon dioxide forms carbonic acid, which lowers our blood pH. We get more acidic. This causes our vessels in the coronary circulation to dilate. It increases the blood flow to the heart muscle. So um, we see a fourfold increase. Why? Because the heart is actively contracting at a faster rate, a more vigorous rate. Depending on the health of the heart, a faster, vigorous rate may be going from 50 beats a minute to 70 beats a minute, or from 70 beats a minute to 90 beats a minute. Um, it just depends. The amount of blood going through the heart may increase, as I said, fourfold. The the flow through the heart, though, does stay constant despite any perfusion changes. You know, we are meeting the needs. We're still sending blood through the heart. We're still sending them through all these coronary arteries and arterioles. We're recovering it in the coronary veins and venules and veins. We return that blood back to the right atria so we can pump it out and use it over again somewhere else, or maybe back in the heart. But we will respond thanks to the presence of carbon dioxide. Carbon dioxide triggers a dilation of the coronary vessels. It also increases our breathing rate so that we can blow off that CO2. We're delivering more carbon dioxide to the lungs. We are blowing off more carbon dioxide. Carbon dioxide is always the driver for increasing our breathing rate in a healthy individual. That's the qualifier, a healthy individual. So now, once we get out to the capillary, we see movement of the gases across the membranes. We see movement of nutrients across the membranes. There is an illustration, an animation of a capillary. And we see the cells on either side of it. This is a plain ordinary capillary here. The arterial is to the left and the venules is to the right. Here we see our cells. They look like simple columnar cells. And you'll notice that we are seeing oxygen go into those cells, and we're seeing carbon dioxide come out. Carbon dioxide is the one with the little gray, the gray molecule, the gray atom with two oxygens next to it. You can see glucose, the little yellow structures are glucose, for example. So we see oxygen diffusing into the cells out of the capillary. We see carbon dioxide diffusing into the cells. Look down here where it says endothelium. You'll see there's a lot of carbon dioxide coming in. We see carbon dioxide going in. We see oxygen going out of the cells, and glucose leaves and goes out of the cells. Oxygen, nutrients leave the blood. Carbon dioxide and waste products come from the cells and go into the capillary. And if you're water soluble, you go through we have lots of openings in the capillaries. They're not a perfect sealed tube. The only place you would encounter that might be in the blood-brain barrier, for example, in the brain, where we have the astrocytes wrapped around the capillaries. But we have clefts, we have fenestrations, we allow nutrients to leave the blood and go into the tissues. We allow waste products to leave the tissues and go into the blood. We have things that are fat soluble go right across the membrane very easily because the fat soluble molecules. Well, the cell membrane of a cell is a lipophosphate mechanism. We have the two fatty acid chains and attached glycerol, but we have in lieu of a third fatty acid chain here for our lipid, we have a phosphate. So we see easy movement across here. Now, in our small intestine, we would see absorption of nutrients instead of just waste product. The cells of the small intestine are going to be requiring oxygen, they're going to be requiring, they're going to be delivering glucose to those cells, but those cells are also going to be passing a large quantity of nutrients into the blood that have to go to the liver for cleansing. So that's where we have those fenestrated capillaries present, lining the small intestine under the simple columnar cells. So, but movement is passive, and we don't have to do anything to get this movement to take place. So, once we get to the what we're seeing here, here we're seeing loading in the respiratory gases and of CO2 and the discharge of oxygen. And here we see on the left, we're seeing a red cell, and it's bright red coming in off the edge of the screen, and then it turns dark red or almost purple. See, because if you notice it, it's inside the capillary here. The oxygen is diffusing out into the tissues. We are loading up CO2, and the CO2 and the reduced oxygen level in the red cell makes it darker. Remember, you're only giving up about 20% of your oxygen at any given time here. So, and this illustration on the left shows you diffusion or movement through the cleft or through a fenestration, for example. There's our membrane. Here's our capillary membrane right here. Here is that's the basement membrane. Here is the movement through the cleft in the membrane in the capillary or direct diffusion. There's a very large, for example, a very large fenestration right there. So problems. There are problems dealing with blood pressure. We have hypotension. In hypotension, our pressure is low. Our systolic pressure is below 100 millimeters of mercury. Hypotension is not necessarily a bad thing. If you are, if your blood pressure is running like 110 to 115 over 70, that is considered very good. The less, lower a healthy lower blood pressure will promote heart health. It will help, your heart is less likely to have issues, because it doesn't have to work as hard to do its job. Generally, people that have a very healthy heart tend to live long lives. Now, the counterpart is hypertension. Hypertension can be temporary, it can be sustained. People can have high blood pressure when they're under a great deal of temporary stress, or when they are sick, they have a fever. If they've been doing a great deal of physical labor or physical exercise, their blood pressure may be elevated. They may have temporary hypertension, and a healthy individual, it will come back down. We tend to consider the magic number for blood pressure to be 120 millimeters systolic over 80 millimeters diastolic, 120 over 80. If we will always have a spike as we do something physical, we climb a flight of stairs, we run, we exercise, we cut the grass, we get up and walk around, we're going to have a change in our blood pressure. That will happen. The problem is when our blood pressure is elevated and stays elevated. And many individuals that have a family history of elevated blood pressure, of hypertension, may see a gradual change in their blood pressure over time as things change in their cardiovascular health. It happens. And so you may be seeing a patient and you've seen them for 10 or 12 years, and you notice that after about 10 years, there's a slight uptick in their blood pressure. And instead of being 120 over 80, now they're running like 125 over 85. or maybe getting a little higher. We don't like to see those upticks, particularly in a rise in diastolic numbers, because that's when the heart is at rest in the diastole phase. That's when the heart is reloading its blood supply. And we don't want to deal with a higher pressure in the heart when it's trying to reload. So stage one, hypertension. Blood pressure is somewhere between 130 over 80 to 139 over 89. It doesn't sound like a significant rise, but it is. Because when the pressure is higher, when the pressure is elevated, the heart has to work harder. And the harder the heart has to work, ultimately down the road, that can cause, the heart gets weaker. We see stage two, where we're considering 140 systolic over 90 diastolic, and while again, we think that a 10 millimeter of mercury change is not significant, it really is because the heart's working even harder. Again, it's the diastolic number that causes great concern. If we see an individual with 180 over 120, we consider that to be a crisis, a hypertensive crisis, because their blood pressure is so elevated, they're running the risk of heart failure, a stroke, a myocardial infarction, nothing good. If an individual maintains a chronic hypertension state, long-term damage can occur to the heart, to the vessels in the brain or in the heart, in the kidneys. It can lead to a stroke. A vessel under high pressure has a greater risk of rupturing. That's what a stroke is. In the brain, a stroke is also caused by a blood clot that blocks a vessel. These elevated pressures run the risk of forming a clot, in here because you're under high pressure. A healthy individual should maintain 120 over 80 or slightly less. And one of the biggest problems with chronic hypertension is that there are no overt signs for years. The elevated blood pressure doesn't show up, rapidly. The blood pressure rises gradually, and it will generally continue to rise. And if untreated, you can reach these elevated states. But it also causes long-term damage. Now, your patient will feel fine for years and not have any overt signs. That's why it's very difficult to get your hypertensive patients to take their medications, their hypertensive, their blood pressure pills, if you will, call them that. They're inexpensive. They work very well. They do things like slow down the heart rate. Some drugs interfere, they're what we call calcium channel blockers. We'll talk about the heart. The heart uses calcium to depolarize the cardiac muscle instead of sodium. So if we block the calcium channels, then we don't depolarize as vigorously. So the heart rate slows down, is less vigorous, and our blood pressure drops. We control the formation of angiotensin to prevent aldosterone release. We interfere with the production of angiotensin in several different ways. The drugs ACEs and ARBs are going to be in effect here. And ACE is an angiotensin converting enzyme blocker. So we don't make angiotensin from the renin, or an angiotensin releasing blocker. So we don't release the angiotensin after we've converted it, but we stop the process before we ever get to the aldosterone or before we ever get to the angiotensin 2 to be a vasoconstrictor. So we control blood pressure that way. There are a variety of drugs that will control blood pressure. And so we can use these, and they're very inexpensive. All your patient has to do is take them on a daily basis. That's the hard part, because people that are taking blood pressure medicine normally feel fine for years. Now, hypotension can cause a problem in some people. We have what's known as orthostatic hypotension. You experience this if you're ever, like I think I used this example yesterday. You're in a recliner and you jump up out of the recliner suddenly, and you get dizzy. what happens is that you've changed your posture and your sympathetic system, which is going to alter the constriction of your blood vessels to move blood up to the brain, doesn't respond as quickly as it used to, or as quickly as it should right then. In elderly people, this is often a problem. They get up too fast, they're going to get dizzy. Uh, you know, Many people, you've been, you're laying down and you get up suddenly, you get dizzy. That's a temporary uh, uh, phenomena that may occur. I don't recommend trying it, but it does happen simply because most of our blood is in the large veins in the lower two-thirds of our body, and we haven't brought them up to the brain yet when we suddenly change position, and our brain is slightly deprived of oxygen for a few seconds, and that makes us dizzy. So that's what we call orthostatic hypotension. Now, chronic hypotension has a couple of causes. The first one is poor nutrition. So that brings us back to our elderly patient again, because our elderly patient may have lost the ability to sense flavors and odors for food and may lose interest in eating and may ultimately be, if they lose an interest in eating, they may become, you know, have become malnourished. That's what I was looking for, malnourished. So it isn't because they don't have the food, it's because they don't feel like eating it. That can lead to hypotension. Less food means less energy, less glucose for energy. So Addison's disease may lead to hypotension. Addison's disease is going to affect the glucocorticoids. And the mineral corticoids. We're going to alter the fluid level in the plasma. We're going to alter the amount of glucose available, and so that can cause lower blood pressure too. Hypothyroidism. You don't have enough energy. Your thyroid isn't functioning well. There's not enough energy. You're not releasing enough thyroid hormone to stimulate metabolic activity. And again, you don't have adequate movement of blood, adequate constriction of the vessels, adequate heart rate, blood pressure drops below a safe level. Acute hypotension occurs when your patient is experiencing circulatory shock. This is particularly when they've had significant blood loss, for example. Patients that are undergoing surgery, they're sedated, their body systems are reduced. They may have lost blood. They may be losing fluid during the surgery. They can have this is again what we refer to as acute hypotension. It can be very critical if your patient starts crashing at this point because their blood pressure has dropped well below a safe level. Consider another example. Consider your patient, a male patient that is coming into the emergency room with chest pains, likely having a myocardial infarction, a heart attack, and they have taken an erectile dysfunction drug. We know erectile dysfunction drugs are going to cause a systemic vasodilation to increase blood flow. Well, this systemic vasodilation lowers blood pressure. And if protocol says give this patient a nitroglycerin tablet, and the patient does not admit, they're asked, have they taken an erectile dysfunction drug? And if they won't confess they have, and they're given the nitroglycerin is also a vasodilator. And now you've vasodilated the vessels twice. So are you going to throw them into a state of acute hypotension simply because they wouldn't confess to taking an erectile dysfunction drug? So it happens, or it can happen. Okay. And as I said, wait, I think I said that already. Am I going the right direction? Yes, there we go. Okay. Hypertension. Can't emphasize this enough. Transient or persistent. Two types of hypertension. Primary hypertension, we get this from diet, a change in our diet. High fat, high carbohydrate, low exercise lifestyle and diet, obesity. If our body mass increases, then we have more blood vessels thanks to angiogenesis, which gives us more blood, which means our heart has to work harder, which means our blood pressure goes up. All these other factors, heredity, race, stress, smoking, because nicotine is a vasoconstrictor that will raise blood pressure. These are all risk factors. Long-term exposure, long-term changes in diet and obesity, are going to can contribute to a rise in blood pressure and create hypertension. Secondary hypertension occurs when we have a problem with too much renin. We release too much renin, activate too much angiotensin, which is a vasoconstrictor in itself, which also is going to stimulate aldosterone, which raises our pressure. Arteriosclerosis, the so-called hardening of the arteries. Blockages in the coronary arteries or in the cerebral arteries will cause a rise in blood pressure because the heart has to work harder to get the same amount of blood through the partially blocked or fully blocked vessel. So, endocrine disorders, aldosterone may be getting released, stimulated by the adrenal gland and by the pituitary gland and not by, renin angiotensin. So we may be secreting aldosterone for no reason whatsoever. Again, raising blood pressure. So blood pressure is such an important component here. We can't emphasize enough that hypertension, is the risk, the risk caused by hypertension ranks right up there with coronary artery disease as far as, affecting the quality of life. Okay. I think the last thing we'll address here is what we call circulatory shock. What happens when your patient bleeds out? They're losing blood. They're losing blood volume. They're losing red cells, they're losing white cells, and they're losing plasma when they're bleeding out. These cells, the tissues aren't getting supplied with their glucose needs and their oxygen needs and the waste removal needs. So this is what we call circulatory shock. We have hypovolemic shock, where we have a low blood volume. Okay, your patient has suffered trauma. They are bleeding out somewhere, and you have to try and control that. What is causing the blood loss? Control the blood loss. Because if you lose enough blood volume, your patient's going to die. They're going to bleed out. You don't have to lose all the blood to die. You have to, if you lose enough blood, the heart will stop working because it's working as the heart will pump faster and faster and faster as blood pressure drops because blood volume is dropping. The heart's trying to compensate, and your patient's in hypovolemic shock. That's a killer. Vascular shock. Okay, you have a patient who has been stung by a bee. They are allergic to bee venom. The bee venom triggers a body-wide inflammatory response. Now, the inflammatory response is triggered by the release of histamine. Histamine, which normally protects us against irritants, histamine, which causes us to sneeze, not sneeze, but to let our nose run when we're exposed to pollen. Histamine released on a systemic basis because of exposure to the bee venom will cause a body-wide vasodilation of the smooth muscle around our arterioles. And not only that, but it will increase the leakiness of the capillaries so that you increase the blood flow through the body to try and deal with this bee venom, but you're also making the vessels leakier, And so as you increase the blood flow, plasma is leaking out of the vessels at a greater rate and going into the tissues. So this is extreme vasodilation. Your patient's going to swell up because that fluid has to go somewhere. It's been said a person stung by a bee. There are numerous cases reported where a person's head has swollen to twice its size in here. So it doesn't have to be, it can be shellfish, it can be peanuts, it can be anything that would trigger a body-wide, a systemic allergic reaction. So when you have this massive vasodilation, you don't have enough, you've lowered your pressure. You've lowered, you don't even have to be an allergic reaction. You have this vasodilation, the blood vessels all dilate together, and the blood flow slows down, the blood pressure drops drastically. The heart is working harder to try and pump blood, but the vessels are so large, the flow is and so slow. And of course, if you have a bee sting or a shellfish reaction or a peanut reaction, for example, then what's going to happen is you're losing plasma to the tissues. You have edema, swelling, because thanks to histamine, your vessels become very much leakier. I don't know if that's good grammar or not. They leak more. Okay. Vascular shock. Those are the problems we have with allergic reactions, among other things. Cardiogenic shock is a failure of the pump to work. The heart becomes weaker. We have a condition known as cardiac myopathy. Myopathy means the muscles are getting weaker. They can't contract as well as before. And so they can't pump the blood adequately, and the heart is failing. You know, uh, you know, when said someone died from heart failure, well, what does that actually mean? Heart failure is a specific condition. It's not a generic. It's used as a generic term. Heart failure is more of a specific term. So, but in cardiogenic shock, the pump can't work properly. Is it the left side failure? Is it the right side failure? Are both sides failing? When we have pump failure, cardiogenic shock occurs, we generally see the heart enlarged. As the heart enlarges, it is less and less efficient. Like a lot of organs in the body, when it's not working properly, it will get large to try and compensate. The compensation doesn't work. I once got to see a cadaver at Pellissippi. We used to be able to take classes over to the cadaver lab at Pellissippi, and we were looking at an individual who had died from heart disease, and his heart was the size of a football. Typically, our heart's the size of our fist. So they had died from essentially, cardiac myopathy. The heart could not keep up with the demands of the body. And that is the end of blood vessels and blood pressure. And I'm going to stop us here, and I will post this video for everybody to look at. It'll be on YouTube later today. And I will have, on Monday, we will meet in class in Morristown. I'm in Sevierville right now. We will meet in class in Morristown, and we will start the heart heart physiology discussion. We will meet again in class next Thursday in Morristown, and that'll be the day we dissect the cow hearts that we have. Also, on Monday, we will do our lecture on the digestive system in lab. So that'll be how Monday hopefully should go. And if you have any questions, obviously you're not online right now, but if you have any questions, go ahead and email me, and I will be happy to answer them for you. And again, thank you for your patience. I did not plan today to go like it did.